This is going to be Critical Care Pharmacology, Part 6, Neurological Drugs. Anti-epileptics and miscellaneous neurological drugs is what we're going to cover in this section, the anti-epileptics pretty much inhibit aberrant electrical activity in the brain, and they do this to prevent or control seizures. First drug on our topic here, our first drug on our list here is going to be Phenytoin sodium or Dilantin. CNS agent, anticonvulsant, and hydantoin, my apologies. Actions thought to act on the motor cortex, stabilize seizure threshold, have antidysrhythmic properties also, and it kind of works like lidocaine, and that's because it works through sodium blockade. This is going to hold the same classification as lidocaine does as far as Von Williams or the antidysrhythmic classifications. And it's going to stabilize the sodium channels, action potential, uses a sodium potassium pump, and by doing this, decrease seizure threshold. Indications: grand mal or complex seizure activity. Contraindications: allergy to phenytoin, hypoglycemic seizures, cardiac dysrhythmias, bradycardia, heart blocks, and that's because of the sodium channel. And sick sinus syndrome, and that one just needs added to that list as well. Side effects: ataxia, slurred speech, confusion, CNS depression, nystagmus, we might get some eyeball bouncing, hypotension and rapid administration, gingival hyperplasia with prolonged use, tissue necrosis with extravasation, and that means if you get it outside of the IV site, it's not going to be healthy to the surrounding tissues. Dosing on this is going to be 10 to 15 mics per kilogram slow IV push over 30 minutes, or 1,000 mic loading dose. Maintenance dose is going to be 4 to 8 mics per kilogram slow IV push. Pediatric, less than 2 years of age, 40 to 60 mics per kilogram slow IV push. 2 to 10 years of age, 20 to 40 mics per kilogram slow IV push. And then greater than 10 years of age, you're going to treat it the same as an adult at 10 to 15 mics per kilogram slow IV push. Special considerations: incompatible with dextrose-containing IV solutions. So normal saline is going to be your drug of choice to mix this with when dripping it in. Do not administer faster than 50 milligrams per minute. Use cautiously in patients with hepatic and renal disease, and that's because with hepatic disease, the Dilantin and the lidocaine both form an active metabolite in the liver. So this is going to be problemsome. And then with renal disease, this is how we're going to eliminate it. So both of these will be complicated if you use it on a patient with those hepatic or renal diseases. Phenobarbital Sodium, luminol, class CNS agent, anticonvulsant, sedative, hypnotic, barbiturate. Actions: inhibit nerve impulse transmissions in the cerebral cortex via the ascending reticular activating system. Depresses the CNS, exerts hypnotic effects, controls the spread of seizures by raising the threshold of the motor cortex stimuli. And this is a natural CNS, or not so much a natural, but phenobarbital or barbiturates are a natural CNS depressant, if you will. I mean, these will depress your entire CNS activity. Indications: grand mal or complex partial seizures, eclampsia, need for sedation. Contraindications: allergy to any barbiturates, significant hepatic, respiratory, or renal disease, and significant hypotension. Side effects on this: sedation, bradycardia, hypotension. Long-term use of this will probably lead you to a vasopressor faster than you would like. Respiratory depression, nystagmus, confusion, ataxia, somnolence. Dosing on the adult: 100 to 250 milligrams IV over 5 minutes. Pediatric: 10 to 20 milligrams per kilogram IV over 5 minutes. Special considerations on this: monitor for respiratory depression and use cautiously in the elderly and patients with renal failure. Fosphenytoin sodium, or Cerebyx, class is going to be a CNS agent, anticonvulsant, and hydantoin. Action: thought to act on the motor cortex, stabilize seizure threshold, exhibits antidysrhythmic properties as well, and it also works like lidocaine, and that's because you get a phenytoin derivative from this. Indications: grand mal and complex seizure activity. Contraindications: allergy to phenytoin or hydrodantoin products, hypoglycemic seizures, cardiac dysrhythmias, bradycardia, heart blocks, or sick sinus syndrome. Now, all of these are because of its actions that it'll actually affect the heart as well. Side effects on this are going to be ataxia, slurred speech, confusion, CNS depression, nystagmus, hypotension with rapid administration, gingival hyperplasia with prolonged use, tissue necrosis with extravasation, or if you get it outside of the IV. Dosing: 15 to 20 milligrams. 15 to 20 milligrams per phenytoin equivalents per kilogram. Now, what that means is this is dosed in phenytoin equivalents, because the dosing on this is going to give you phenytoin. Maintenance dose is going to be 4 to 6 milligrams phenytoin equivalents per kilogram, slow IV push. Special considerations on this: use cautiously in patients with impaired hepatic, renal, or pulmonary function. Do not administer faster than 100 to 150 milligrams per phenytoin equivalent per minute. Keep refrigerated before administering. Miscellaneous neurological drugs. Mannitol or Osmitrol. Class on this is going to be an electrolyte water balancing agent or osmotic diuretic. Actions on this: acts as a hyperosmolar agent, draws interstitial fluid into the intervascular space, increases glomerular filtration rate, and this is going to mean increases urination, decreases sodium reabsorption, and promotes water loss. What this is going to do: this is a very thick, viscous substance. It has a higher osmotic pressure than the fluid that you introduce it to. So very simply, if you introduce it into the vessels, it's going to pull fluid from the cell and then pull fluid from the interstitial spaces, and all of this increased osmotic pressure and vascular pressure will be utilized, or actually will be filtered through the kidneys. The kidneys' glomerular filtration rate, or their urine production, will increase, and you will pee more water out. Now, what this does for us as far as a head injury patient is, by dehydrating the cell, it shrinks it, thereby reducing intracranial pressure. Indications to increase intracranial pressure. Contraindications: hypotension, dehydration, acute pulmonary edema, anuria, not making any urine, or known allergy to the drug. Side effects: hypotension, dehydration, acidosis, and electrolyte imbalances. Dose on this is going to be 1.5 to 2 grams per kilogram IV push over 30 to 60 minutes. Special considerations: use cautiously in patients with blood loss, hypotension, and dehydration. They are not going to need the fluid shift as much as the others. Monitor urinary output closely. Be alert for transient hypertension. Use cautiously in patients with poor left ventricular function or renal disease. The left ventricular function, you could easily throw them into heart failure by this maneuver, increasing the afterload pressure, or increasing the actual blood pressure. That's what it will do very quickly in the first 20 minutes of its onset. And this drug will hopefully make the kidneys work harder and get the fluid out. However, if the kidneys are having some problems eliminating the fluid, and you're doing this for intracranial pressure, this could have actually kind of worked in your disfavor. By increasing the pressure, it would increase intracranial pressure. So you're betting on the kidneys working before you use this medication. Methylprednisolone or Cerebyx. Class on this is going to be a hormone and synthetic substitute. Corticosteroid, glucocorticoid, anti-inflammation. Actions: acts as an anti-inflammatory agent, exhibits immunosuppressive properties, and this is it mimics a corticosteroid or glucocorticoid, which is your body's own natural steroids. This medication, we use it most of the time for breathing disorders like asthma attacks, so we can decrease inflammation at those sites. But the indications here are going to be also for spinal cord injury. Now, there is some evidence out there that using it for spinal cord injury is not exactly the best thing to do. That it gives them a greater chance of having complications later on. Indications on this: chronic and acute inflammation and swelling, bronchospasm, and then spinal cord injury. Contraindications: suspected fungal infection. Very simply, if this is going to depress the immune or suppress the immune system, if you have a fungal infection, your immune system isn't what it should be to begin with. And then known hypersensitivity. Side effects: edema, hypokalemia, hypotension, hypertension, hyperglycemia, congestive heart failure, and delayed wound healing. Now, the whole steroid thing will increase your blood sugar or your body's production of glucose. Hypotension and hypertension depends on how your body reacts to it. Most of the time it will give you a little bit of an adrenergic response, which should give you a little bit of hypertension. It can make you hypokalemic from its direct actions, and it can cause edema or third space fluid shifting. And it definitely will delay wound healing. Dose for a spinal cord injury is going to be 30 milligrams per kilogram IV over 10 to 20 minutes. This is a very high dose. Most of the time we do not carry that much on our truck. A 100 kilogram patient would take 3 grams of this. Most of the time we carry it in the version of 125 unless we have special dosing and special high concentration versions for spinal cord injury. Maintenance infusion, 5.4 milligrams per kilogram per hour for the next 23 hours on the spinal cord injury. In bronchospasm, we give a one-time dose of 40 to 125 milligrams IV over about 2 minutes. Special considerations: use cautiously in patients with Cushing syndrome, GI ulcerations, diabetes, and psychotic tendencies. Monitor for hyperglycemia in the non-diabetic patient. Dexamethasone, Decadron, is a hormonal synthetic substitute for corticosteroid or glucocorticoid. Actions: has a potent anti-inflammatory property, crosses the blood-brain barrier, plays roles in managing increased intracranial pressure, and this would be another thing that we can actually use. This is used for high altitude edema as well. Indications: adrenal insufficiency, concomitant with mineralocorticoid use, so your adrenaline glands pretty much went kaput. Inflammatory conditions, allergic states, collagen's disease, hematological disorders, Addison's shock, neoplasm, rheumatic disorders, and inflammatory GI disease. Contraindications: known allergy to the drug, systemic fungal infection, tuberculosis, or varicella. Side effects: edema, hypokalemia, hypertension, hyperglycemia, congestive heart failure, and delayed wound healing. Dose on an adult: 1 to 2 milligrams per kilogram with a maintenance infusion of 1 to 1.5 milligrams per kilogram, tapered dose over about 4 to 6 hours. We don't want to take somebody directly off this and just let them they need to be tapered off of it or slowly taken off of this medication. Pediatric, 0.5 to 1 milligrams per kilogram. Special considerations: risk of congestive heart failure. Use cautiously in patients with hepatic or renal disease, GI ulcerations, diabetes, seizure disorders, or psychiatric disorders. Nimodipine or Nimotop, class on this is going to be a cardiovascular agent, and it's a calcium channel blocker. Action on this is going to be block the calcium channels and relax the smooth muscle. Preferentially binds to cerebral arteries and achieves cerebral vasodilation. Indication, vasospasm associated with subarachnoid hemorrhage. Contraindications are going to be lactation. Side effects, hypotension, because this is going to work systemically. Tachycardia, which that may be rebound from the way that it works. EKG abnormalities, GI bleeding, and peripheral edema. Dose on this, 60 milligrams PO or nasogastric every 4 hours, administered within 96 hours of subarachnoid hemorrhage, continued for 21 consecutive days. Special considerations, caution when administered with other calcium channel blockers, and you're just going to overdo it. This ends part 6. If you have any questions, feel free to email me, Roy Smith, roy.smith@redlandscc.edu or smith@emsa.net. Thank you.